moving towards the next session, it will be a very gripping. HbA1c and CGM both used to estimate average glycemia for people with diabetes, but the relationship between the two varies over time. Now we are going to witness a jaw-dropping tie break between these two. To ease out the situation and to break this tie, we have our next eminent speaker with us, Dr. Kaushik Pandit, Chief Consultant Endocrinologist, Bellevue Clinic, Research Scientist, Department of Endocrinology, IPGM here, Kolkata. And to chair this particular topic, I would like to invite Dr. Sanjay Kesha, the founder, president, and HOD Diabetes and Endocrinology, Narayana Super Specialty Hospital, Howrah, and Dr. Professor Dasharuthi Shorka, senior consultant endocrinologist, Calcutta Medical Center, GD Diabetes Hospital, former faculty, ACES Hospital. I would like to request both the chairperson to please come over the stage and introduce our eminent speaker.
Good morning, everyone. Sanjay, how is Sanjay?
Yes, sir.
Anyway,
You just start, he will join you shortly.
We know for the diabetes management, glycemic status is very important. We'll have to judge the sugar status always. There are so many metrics are there. Initially, SMBG, that is self-monitoring of glucose, was important, but now there are some fallacies is there. Some new metrics has come. The HbA1c is a very good gold standard matrix, but it has some fallacies is there. And so the newer matrix has come, CGM, the continuous glucose monitoring. And practically HbA1c cannot detect the fluctuations, the glycemic excursion and glycemic variability. And the hypoglycemia, particularly important is hypoglycemia. It fails to detect the hypoglycemia. There is extreme varieties, hypoglycemia is very much detrimental. And CGM covers all these things. And now the stage over Dr. Kaushik Pandit. And Kaushik is now the president-elect of the Endocrine Society of India. And let us see over to Kaushik.
Respected Chairperson, sirs, my respected seniors in the audience and dear friends. It's indeed an honor to have been invited in such a gathering. And thank you really for the invitation. Well, we all deal with diabetes, a stage of hyperglycemia. So to treat that one, we need to treat the excess amount of glucose. And while doing so, like blood pressure, we need to measure it. But what do we measure? Blood sugar, like blood pressure, is a very dynamic entity. So it changes every second to second. So it becomes all the more difficult to gauge how things are behaving with a dynamic parameter. And while treating diabetes, we are convinced of the fact that you need to go for tight glycemic control, and tight glycemic control gives you all the benefits. We are convinced about that. But what do you mean by the word tight glycemic control? That means, where do you draw the line as to what is good, what is bad, what is tight, what is loose, what is poor? It obviously is based on not only glucose, but something else. Because you know, just because glucose is dynamic, it probably won't serve your purpose. So merely testing with fasting and PP sugar, you will not be in a position to understand the whole picture of one particular biological state. And to obviate that, a very interesting aspect of average glycemia measurement. And long ago, nearly 3 decades ago, one particular parameter came, what is known as glycated hemoglobin, which is glycation of a protein, especially the hemoglobin, which gives you an idea about the average glycemia that the biological state is therein. So with that measurement, and that's glycation of a protein, it probably served our purpose, because it gave us as to which way should we go. I mean, there is something what is normoglycemia, there is something what is known as hyperglycemia, And people have been put into tests, and we have found that something which is less than 7, which is useful, and that changes according to the situation. In many patients who are elderly or too sick, we probably should not go for a very tight glycemic control for very obvious reasons. But does that serve the purpose? The title of the talk is HbA1c versus CGM, meaning probably that one is pitted against the other, which actually it is not. The two are two different things, and two need to be taken into account from two different angles. They should not be looked upon as one something which supplants the other, or which supplants the other, not looked upon as it is something against each other. Now let's get into little detail about it. HbA1c, which measures the average glycemia, which is a statistical average with a maximum contribution for the last 30 days. But the total glycemic burden of the last 120 days, roughly 3 months, is reflected there. But the maximum amount, of nearly 50% of its contribution comes for the last 30 days. So it gives you an average glycemia of last 30 days. Does that serve your purpose? Yes, it does, but to a certain extent. Because there are many situations where this might not serve your purpose. Like, say, HbA1c have been used as a diagnostic marker for diabetes. But we must also remember that elevated fasting and elevated glycated hemoglobin are not synonymous. In fact, if you go by elevated fasting alone and if you go by elevated glycated hemoglobin alone, they are two different population groups. One important aspect of average, whatever average that you talk about, any average from your class 4 standard, we know average is something which gives you the middle part of that story. But many times that middle part probably does not serve your purpose, because many times we really need to see the scatter and we really need to see the variation, which glycated hemoglobin cannot really provide. And many situations, glycated hemoglobin might not reflect the internal status. Like, say, for example, we have got 3 patients. All of them have got a glycated hemoglobin of 7.0. In one, if you go by their daily SMBG curves, you will see that the one which is measured in red has got too much of fluctuation. The ups and downs, the zenith and nadir are too widely apart. Compared to that, the gray one, which is little less, and the least fluctuating one is the yellow one. But remember, all of them have got glycated hemoglobin of 7.0. Does that really mean that all 3 are the same group of patients or the same pattern of patient, same complication set of patients? Unfortunately, no. Because people who are having too much of ups and downs are prone to develop spikes of hyperglycemia and nadir of the hypoglycemia. And they are the ones, so to say, a brittle diabetes. So brittle diabetes can have a perfectly normal glycated hemoglobin, giving you a false sense of security that probably you are doing right. But if you measure more frequently throughout the day, this probably gives you an idea that we probably are not doing the right thing that should be done. So here comes an example. We are having same glycated hemoglobin, the fluctuation, or what is technical term known as glycemic variability, are pretty wide. So somebody who has got very little glycated hemoglobin is painted in green, and the yellow part is the one which goes up, the red part which is really down. So the red one, 50% time it is more than required, 30% times it's less than what is required. So it's certainly not desirable. So here comes a situation where glycated hemoglobin probably will not give you the total picture of the situation. So that is why you need to have a continuous glucose measurement, because there it reflects the dynamicity of the situation much more intensively than a glycated hemoglobin can. Like every test, all tests, whatever test that you can think of, like medications, have got their flip side. And you can say these are the something what that needs to be taken into account and so to say taken in our stride, and we use it that way. Whatever test, talk about fasting sugar, PP sugar, lipid, etc., all measurements suffer from some limitation. And like that, glycated hemoglobin also suffers from a limitation. The important limitation is that the standardization of the test is rather quite difficult. As of now, we have, so to say, understood that we should follow one particular method. That is an HPLC method, which is sort of used in the DCCT clinical trial. And that's done by what is known as technically and commercially known as BioRad. There are many other methods. I will not say they are bad. Many of them are very good, pretty good. But the one which is standard is the BioRad method. And one important aspect, just because it measures the glycated aspect of the hemoglobin, if there is a structural change in the hemoglobin, or what is known as hemoglobin variance, which is only but natural, like every protein in the body, it undergoes a bit of a variation. So if there is a variation in the structure, the tertiary structure of the hemoglobin, the glycation also suffers either more or less. So in such a situation, in a variant hemoglobin, it becomes all the more difficult to standardize that one. The important variation are hemoglobin F, hemoglobin D, hemoglobin E, etc., and they are not that uncommon. So a situation which is as common as diabetes, affecting nearly 50% of the population in a adult population, there this incidence of hemoglobin B or D or E will not be very low. So in such a situation, it becomes difficult to standardize the methodology of HbA1c measurement. So the various methodology that are there, ion exchange chromatography, boronate affinity chromatography, HPLC, of that HPLC is regarded as the standard. But there are hordes of reasons why HbA1c should merit the very important measurement of glycemia. It measures the chronic hyperglycemia. One very important that it can be taken any time of the day or night. It is very importantly associated with complications of diabetes, just because we have been using it and using it as a marker for hyperglycemia for patients with diabetes. So you just name any complication of diabetes and you want to associate it with, we do have all the data inbuilt, so you can fall back on. The microangiopathic complications are strongly related to the distribution of glycated hemoglobin, so it becomes all the more easy to extrapolate that data in an individual patient. So if somebody's glycated hemoglobin is 9.5, you know it beforehand that the person is suffering or will be suffering in short while the microangiopathic complications of diabetes, but you cannot be very confident about the macroangiopathic though. And it does not get affected by the stress, diet, exercise, smoking, like the standard sugar measurement does. And the analytical stability of this particular glycated product is very strong. So we do have a lot of merits, principally because it is stable and it has been tested for long, and it is the, so to say, gold standard of diabetes measurement of glycemia associated with the complications of diabetes. But there are, of course, reasons not to prefer glycated hemoglobin. I would say there are not many. One important aspect, of course, would be cost. The second is it's not available everywhere under the sun because the technology is expensive and not available everywhere. And it cannot be used in some special populations like pregnant women It cannot be used in populations where there is hemolysis, which is much more frequent, like people who are undergoing hemolytic anemia. And it is intimate, just because it is intimately associated with the tertiary structure of the hemoglobin, which is strongly dependent on the ethnicity. So the normalcy of that HbA1c also varies from population to population. Some of the factors which influences is iron deficiency anemia, alcoholism, aplastic anemia, hemolytic anemia, chronic liver disease, etc., and none of them are very uncommon. So you have to use it judiciously. But I am repeatedly saying this one, that till now, whatever study that has been done on diabetes, whatever complications of diabetes is known, it is intimately matched with the glycated hemoglobin. So with measurement of glycated hemoglobin, it gives you a very strong tool to assess the internal situation. Because of the reasons elucidated, we need to have something which can obviate the problems that we have discussed. And that is why we need to have a minute-to-minute dynamicity measurement of the glucose that is undergoing, and that can be done by an SMBG or a CGM. I mean, SMBG is something which is done by the patient, and CGM which is done by the machine. The principal difference is that CGM is done automatically, much more frequently than SMBG is usually done. And that is why one of the great advantages of CGM is that it is not dependent on the person's choice. If I am a person with diabetes and I am doing SMBG, I will do it at my own sweet will, as my time preferred. And in doing so, I might miss very important data on spikes of hyperglycemia or incidences of hypoglycemia. And that is why CGM is the important aspect, not the SMBG, because SMBG cannot really replace CGM. So while talking about the measures of glycemia, we should talk about CGM and not SMBG. Another very important aspect of SMBG and CGM, I might be digressing a little bit, but probably this is important conceptually. With an SMBG, you come with a number, say 160, and that number is a static number. That only reflects, even if you assume that this has been done correctly, it measures correctly, that 160 is the measure of the glucose at that point of time. It does not tell you the story whether the sugar is rising or falling from that point of time. CGM can really tell you that one. Just because CGM is measuring every 15 minutes, it will tell you whether this is 160 at this point of time, and it's a dynamic number, it is going up, allowing you to take some decisions based on that. So we really cannot compare CGM with SMBG. As I've said, person has done SMBG 5 times, and if you put it on the CGM curve, you will see that despite the fact they are in the green zone, just because the person has chosen to do it at that point of time, he has missed or she has missed the spikes and the troughs. And this CGM also gives you some other parameters which are also useful. Like one very important aspect, that it gives you an average glycemic marker. So this average will tell you whether this corresponds with your desired average as is measured by the glycated hemoglobin. So this may be an indirect measurement of glycated hemoglobin from the CGM, assuming that there is not much of inter-day variation. Between the days, there are not much of variation, which of course can happen in people with diabetes who are a little brittle. So if you assume that there is not much of inter-day variation, we can use CGM to measure indirectly the glycated hemoglobin. So that also is a great benefit. And very importantly, it does not, just because CGM measures glucose, it does not suffer from the limitations of HbA1c of measuring a glycated aspect of a protein, which is much more complicated. And that is why it does not get affected by the hemoglobin variation or variance of hemoglobin at all. So that's one great advantage of CGM. From CGM, you can also get a rough estimate of the glycated hemoglobin of that person. It gives you a very important aspect of the variation throughout the day, the standard deviation. This probably is the most important thing because it tells you the story of the variation of the sugar throughout the day or night. If the person is having a brittle aspect of the diabetes, it will send you a signal that probably what we are doing is not right. Sometimes the sugar is going low, sometimes it's high. So you have to look into the CGM record and give you the total picture, what time it is going high, what time it is going low, and you can match it with the medications that you have prescribed. So it gives you a good correlation. Now, what about the correlation of CGM and HbA1c? Well, honestly, you are asking as if comparing an apple with a pear. We cannot really do that because HbA1c is measuring something else, CGM is measuring something else. But some studies are there which try to correlate, what is the correlation between the CGM measurement and the HbA1c measurement. And with the regression curve, we can see that they are reasonably correlated, knowing fully well that the variation that we see here, this dispersion, this standard deviation is much to expect. And you can see that the results are all over the place. It is the measured regression line, and that shows statistically, despite the fact they are correlated, there is wide amount of dispersion in the data. And as I've said, just because they are not same thing, we cannot really compare HbA1c and CGM on the same count. So what are the standardized CGM metrics? It gives you number of days CGM device is worn by the person. Usually it is 14 days. Percentage of time it is active. Not necessarily the person has put it on. It might have cheated by putting it off at many a times. This also gives you a percentage of time the machine is on, and it ideally I'll try to finish off in the desired time. How much amount of time it is being used. It gives you the glycemic variability, percentage CV. Very importantly, it gives you what is the time above target and time below target, and time within target, time in range. So this time in range ideally should be more than 70%, and the time in below target should be less than 4%. So if you can achieve with your patient's data, we can definitely be sure that you are in the right path. I am sure to this August gatherings, I don't need to tell you the importance of time above target and time below target, the hyperglycemic peaks and the hypoglycemic nadirs. And so we can think of this CGM as the new HbA1c, so to say, because it gives you not only the average glycated percentage a person spends throughout the day, it gives you a rough estimate of HbA1c, but more importantly, it gives you the glycemic variability. And people are not falling behind to test it against complications of diabetes, because as I have said, the greatest advantage of A1C is it is sort of married with complication. This has also been done in many tests, and you can see that from this particular study, you can see that this is diabetic neuropathy, this is diabetic nephropathy, this is diabetic peripheral neuropathy, this is diabetic retinopathy, and this is cardiovascular disease. And you can see that time below range, within time in range, time above range and time below range are, and we can see that with time, with increase in time in range, the complication rate is going down. So it is evident that people who are having a good time in range are having much less complication. This has, though I must say there are only a handful of studies, just because this is a new technology. And so this time in range and all-cause and cardiovascular mortality have been shown to be strongly associated, just like glycated hemoglobin. But once again, this has not been tested in multiple studies, multiple meta-analysis. We have not done that one. And the all-cause mortality and cardiovascular mortality are strongly associated with this one. So a graded inverse relationship between time in range and the complications of diabetes have been achieved. So it remains a very important parameter. So time in range can be the new HbA1c to guide you how to use your treatment, whether it is oral or injectable. You know the duration of action of your prescribed oral medication or duration of action of your prescribed insulin, type of insulin, and you can get it into the clinical target. I'll stop here and would invite questions.
Dr. Kaushik Pandit, great talk. Thank you for updating us with respect to CGM and data interpretation. So any questions from the floor? Oh, we have so many questions. Please, take the mic.
Yes, Nirmalada.
Yeah, Kaushik, you have been as erudite as ever. We all know CGM is a better matrix, no doubt about that, but for reasons...
I would say not better, it's different.
It's different, but
It's different
it gives much
and-
more
yeah.
information, as you said, the TIR and all. But the point is, for obvious reasons, we cannot do CGM to most of the patients. We go by HbA1c, right? In that case, my question is, if you look at the Monier's data, right, the fasting contribution vis-a-vis postprandial contribution, different. But in Indian subset, where carbohydrate is much poorer, we spend about 18 to 20 hours in postprandial phase. Do you think the Monier's data is valid for Indian populace, or do you differ and our probably postprandial contribution in HbA1c is much more than fasting contribution? What is your take?
Yeah, very good question. In the sense that Indian people consume more of carbohydrate, and it is likely that we have got more of postprandial peaks. Postprandial hyperglycemia, very important concept. Unfortunately, it has gone out of vogue these days for some reason or other. Maybe because of the advent of the SGLT2 inhibitors, which had not looked into the postprandial peaks anyway to a great extent. But whatever be it, I mean, it is emancipable that in Indian patients, postprandial peaks probably will contribute to more of not only glycemic variability, but of the average glycemia as well. But from a practical standpoint, when I use CGM, I use it in a handful of patients where I assume that the person's glycated hemoglobin probably is not showing right, and he or she might be having more of an fluctuation than I would envisage. And in such a situation, I put that person on a CGM. Obviously, I cannot afford to have all my patients on CGM for obvious reasons. Not only it is expensive, but it is not available and it is cumbersome. And so now you, of course, have got another modality known as flash glucose measurement, which is useful, but once again, very expensive. So I put patients on CGM only in situations where I presume that the person is probably having suspected hypoglycemia, especially if the person have got hypoglycemia unawareness. So used judiciously, this CGM can be a very useful tool in the hand of the physician. Else, not everybody need to be on CGM, but I completely agree with you that probably in our country, if CGM is done more frequently, we will see that postprandial peaks are much more common than it would have been in a Western country. Yes, Satyajit.
Sir, I have one question. We face it regularly in our clinic. When we convince for a patient for CGM, they ask how commonly or frequently we will do the CGM, once in a year or twice in a year.
Unfortunately, just like any newly introduced technique, there is no recommendation because we are also learning. I mean, there are flip sides of CGM as well. So there is no recommendation. I use it as is where is basis. I mean, whenever that is requirement, I usually do not, repeat unless and until I need to see whether with the changed medication, the person has got hypoglycemia and awareness, whether this has improved the situation. So I cannot recall I have done anyone more than twice. And probably you don't need to go for every year testing. Your good old friend of glycated hemoglobin will serve the purpose in most of the situation.
Thank you, sir.
Type 1 diabetes is a very important aspect where the fluctuation is much more. Glycated hemoglobin may not reflect the actual average glycemia, and people with type 1 diabetes have got a higher glycated hemoglobin despite having a reasonably good sugar control and repeated hypoglycemia as well. And there CGM probably is a very important adjunct in the management.
Dr. Pandit, there's only one issue which I have with CGM which I do not know, I can't come to terms with. Hypoglycemia can kill, okay? And hypocalcemia can basically result in major injuries. You are allowing up to 4 or 5% in 24 hours hypoglycemia. I can't swallow it. Is it the limitation of technology today? That is the reason why you are allowing this? No entry, kintu thik ache cycle আর ওই বাইকটাও একটু চালিয়ে দিতে পারিস কিন্তু গাড়িটা চালানো যাবে না I do something that
I guess it's also dependent on the time where the hypoglycemia is happening. Exactly. If it is happening whatever time, say at night, then you have to be doubly cautious, maybe triply cautious. Else we need not be pretty worried. And we must also remember at this point of time that while using CGM, you are measuring the interstitial glucose. It is not the blood glucose that you are measuring. So there can be a bit of a difference between the interstitial and the blood glucose, which is your gold standard, by which you vouch. So obviously that can be one particular aspect that needs to be taken into account as well. Something. So nocturnal hypoglycemia is something, a very useful tool is CGM. And it gives you an idea.
Right. Big hand to Dr. Pandit, I must
Thank
say.
you very
Very interesting session. Thank you very much.
Thank you so much, Speaker. Thank you, Chairperson. Sir, please be there for felicitation program. I would like to request both the Chairperson to please felicitate our Speaker.
It's indeed an honor to have been felicitated by not only my senior from the same college, but my teacher as well, Dr. Dashrathi Sarkar.
Thank you so much, sir.